All right. Hi, everyone. Welcome to today's session. We'll give folks a few more minutes to join before we get rolling here. So I'm going to go ahead and put myself on mute and wait a couple minutes for everyone to join, and then we'll get started. All right, we'll go ahead and get started with today's session. So we're really excited to have so many FQHC leaders dialed into today's session. My name is Jessica Day. I'm on our marketing team here at CareMessage. And our team is really focused on one thing, and that's helping FQHCs better care for their underserved patient populations through texting specifically at scale. And so that's why we host learning opportunities like this webinar, for example, for FQHCs across the country to just be able to gather together virtually and just share learnings related to patient engagement with one another. So before we dive into today's session, I'll first share a few logistical details. So today's session is going to be a 30-minute presentation. We'll also have a 15-minute Q&A at the end of the presentation. So feel free to, there's a button at the bottom of your screen that should say Q&A. Feel free to click that button and insert any questions that you may have throughout the presentation, and we'll be sure to address those either at the end of the presentation, or if we don't have time to get to any, we'll certainly follow up with you via email. And then after the session, we'll be sharing a recording with everyone via email after today's session. And so today our speaker is Isaiah Nathaniel. Isaiah is a technology business leader and the Chief Information Officer of Delaware Valley Community Health. It's a Pennsylvania FQHC in the Delaware Valley. They have over 300 employees and serving over 48,000 patients across 8 locations. Isaiah is responsible for developing and executing the overall information system strategy in support of the business plan and strategic direction of the organization, and specifically in the areas of security and maintenance of their IT network, integrated EHR, electronic practice management, and their electronic dental record hardware and systems. So we're really excited to have him here. He's a really great speaker, and he's going to be sharing some of his work and learnings with us today. So Isaiah, I'll go ahead and hand it over to you.
Thanks, Jessica. Hello, everyone. Nice to meet you all virtually, and I thank you for spending a few minutes with me. But I want this to, at the onset, just to be a collaborative experience. So I'm really looking forward to the last half of this session where the questions come out, because I'm always in learning mode, and hopefully some of your questions and or advice can help transition the way we do some things here. But for the purposes of today, I want to take a few moments just to, one, tell you a little bit about myself. I've been in the FQHC world at Delaware Valley Community Health for about 11 years, and I come from the for-profit sector, but making the transition over here was easy because of the missions, and that's the missions that we all are a part of. And I feel like this FQHC community as a collective is a great community to be a part of. And my job now as CIO is to broadcast that internally and externally outside of the building here. And CareMessage is one of the opportunities for us to do that. They have provided a great platform for us, and we look forward to the next steps of our relationship, which we'll talk about a little bit later. To start, let's start with us by the numbers. Now, we all know during this time, pretty much everyone should have just finished submitting their UDS numbers, so this slide is a little outdated as of a month, right? So right now, before it's even actually submitted and actually approved, where we think we will be is an increase from last year, 2018, to now 49,050 patients, which then in turn turns for us 585 visits. And we still have that same 9 locations. We've increased some of our employees. We're about 312, 311 right now. And we've been in business for 50 years. We have 4 main sites and 4 satellite sites, and some of that we'll talk about a little bit as we continue to go on. So who are we? So the first thing I want to talk about is this triple aim. And the triple aim, a lot of us know, that comes from the Institute of Healthcare Improvement. And they've coined that term, the triple aim, which has the reducing costs, the patient experience, and population health. And then us in the IS industry and the healthcare industry, we really think that this core triple aim is about improving patients and improving their lives. The triple aim measures and put patients at the center of care, and any modifications to that original triple aim should not take us away from our highest priority, which is patient care. But that doesn't say anything about the providers in this triple aim. And a lot of us have articulated and argued for an addition to this triple aim. So when we talk about the triple aim, the next thing that comes to mind is the quadruple aim. And the quadruple aim, it takes that triple aim and then it adds the provider well-being to that. Now, for me as a CIO, I find that to be very, very indicative of sort of my everyday job. And the reason I say that is because if we're not providing the proper care, if our 74 providers are not providing care at the point of care using the technology that they have at their fingertips, then we fail. And so my job is to make sure that this provider well-being is a part of the complete picture of this quadruple aim. So although the Institute of Healthcare Improvement does not recognize the quadruple aim officially yet, I do. I recognize it as being a part of this continual conundrum of producing the right technology at the patient level that improves quality, improves outcomes, and then from the business perspective, it improves costs. And then it adds revenue to the bottom line. So you may be saying, you know, Isaiah, this is cool. We all know this. We all know what's going on. But what does this do for us? How does this align to the topic at hand? And I'm so glad you asked, because aligning this to both a business and technology perspective, it will help you achieve this quadruple aim and position your teams to be the best that they can be and drive providers further and further away from what is called moral injury. And I just want to give you some of the steps that I have done here at Delaware Valley Community Health to produce that. So to err is human. We all know this. It's a part of everyone that is a CIO. It's a part of our core training is this err is human kind of Institute of Medicine report. And the scope of medication errors is at an alarming rate. Each year in the US, serious preventable medication errors occur in a 3.8 million, and that's for inpatient admissions, and 3.3 million for the outpatient visits. Now, the Error is Human report estimated about 7,000 deaths in the US each year are due to preventable medication errors. I want to say that again, and this is an old report, but the numbers are still staggering, that it estimates 7,000 deaths in the US each year are due to preventable medication errors. So the cost of medication errors from an inpatient preventable perspective is about 16.4 billion annually. And for the outpatient perspective, to which we all are, this community, it's about 4.2 billion annually. Dosing errors make up 37% of all preventable medication errors. Drug allergies or harmful drug interactions account for 11% of these preventable medication errors. Preventable medication reconciliation occurs in all phases of care. 22% during admissions, 66% during transitions in care, and 12% during discharge. and approximately 100 undetected dispensing errors can occur each day as a result of the significant volume of medications dispensed. So I'll stop here for a moment and talk about why this is at the core of me. Because information systems, our job is to prevent this through the use of technologies. It's why we all have jobs as CIOs. It's why we all are in healthcare. It's why we must take an approach of preventing this at where we can make a direct impact that then would drag these large national goals down. And it's my position that this FQHC community has a great leg and a great onus on ourselves to do that. And it's by the way of technology. Health information technology, HIT, is part of the equation that participates in improving healthcare quality and reducing medical errors. So what do I mean by that? When you understand IT or IS as a business, that's where the job of a CIO exists. And FQHCs are behind the curve in understanding this very fundamental charge of care from a technology side. It's cute to have a network administrator, it's cute to have an informatics person, and it's cute to have a desktop support. But we as a community are missing the bigger picture of really what is at stake. We're missing that we are a part of this healthcare environment where if you put the past two slides together, it starts to become clearer. And so here we have, and this is just a level set for us here. This is my idea of what information systems is. Now, obviously there is evidence behind this, but for the FQHC perspective, I think it's always important to have a slide like this to indicate exactly how your information systems department should function. There should be the traditional information technology department, and then there should be the traditional information systems department where HIT falls as a subset of that. The information technology, if you want to layman's it would be your hardware, your switches, your servers, all of those things. From the software perspective, that's the information systems perspective. That's the support of the business through the use of software. And then we have the HIT, which is a focus specifically on healthcare technology. That's the EMR, that's the EDR, that's the EPM. That's specific to healthcare, and that's where HIT derives itself from. So my impact to DVCH as a CIO, next slide, please. I just wanted to put this out there because this is what's under my charge. And under my charge is not only the IT side, it's the IS side, and including meaningful use. That is the proper alignment of meaningful use. Now, you can say it's a slow drag or conundrum to informatics and or pay for performance, but its true home is in meaningful use. The actual HITECH Act that was put out, including meaningful use for information systems, and it should be governed under that. And that is my personal and evidence-based feeling on meaningful use. And we can have a lot of conversations about that. I'm hoping I get a couple questions on that. But from a DVCH, Delaware Valley Community Health perspective, this is all of the things that are under my charge. It's our databases, it's our stakeholders, it's our HIEs, it's our business, our patients, our business, our respect, and our data. And these are all of the service lines that we have. So DVCH as an organization, to that very first slide, as we talked about before, been in business for about 50 years. Our service lines are peds, adults, optometry, dental, behavioral health, MAT, OBGYN, podiatry, and then women's health. And we refer to our local hospitals for labor and delivery. So that's a large scope, and that's a large charge for technology. But if you look at it from this perspective, it is manageable. And if you have the right team to do that, you can do such. So how do you achieve the proper balance? That's the patient's experience versus the provider well-being. So from a technology perspective, you have Apple Watches, you have cell phones, you have the patient wanting to understand what's going on with their health. From the provider's perspective, they want to have the vitals, they want to have the medications. They want to have all of the soap information. They want to have all of the episode of care information. They want to have all of this information at the time that the patient is presented to them, and they want to get them in and out according to proper technology being useful and efficient for them. So where does that balance come? How do you say that this should be the priority of your IS staff? I think it's both. I think you have to look at it and say, we have to provide the patients the experience they want, but we also have to take into account the providers being able to do the things that they want to do. So provider well-being, if we were to break it down, there's a 4-step process to that moral injury that I talked about before. First, it's the EHR. No provider likes EHRs, none of them. Now they have to click all over the place. 2, workflow inconsistencies. We have 9 sites, and I'll be transparent and say we do have some workflow inconsistencies because you are dealing with 9 different ways of operating, different demographics, different patients that present themselves. So you may have to change that. But how does technology, how does your information systems department handle that? It's at the workflow level. Then 3, they start to lose passion. It's a combination of 1 and 2. If they do not understand, them being the providers, if they do not understand what is the proper workflow, then they're just going to burn themselves out. And then you put the management, the senior executive pressure on that for productivity. That's how you burn providers out. So when you look at that, what is the pillars of primary care? Providers were not trained to be informaticists. They were not trained to use technology. When you look at their daily life and the things that they have to do per patient, here are the 7 things that they're charged to do. They're charged to do health promotion, disease prevention, health maintenance, counseling, patient education, diagnosis of acute disease, and treatment of that same acute measure. That's a lot of things to do. Nowhere on this list is click a box for meaningful use. Nowhere on this list is you got to make sure this medication is reconciled appropriately. So this is their charge. How do we give them the tools necessary to make them applicable? I don't know. We polled our providers. Next slide, please. We polled our providers and we said to them, be honest with us. Tell us exactly what you like or dislike about the EHR. Now, here's the thing. We use NextGen, and I see that you see it here. We love, from an IS perspective, we love our vendor, our EMR vendor. But this is for all EHRs. They say it's slow, it's cumbersome, it's frustrating. Some say it sucks. It's adequate, it's mysterious, it's grumpy, it's glitchy. You will get this with any provider that you talk to. They will have the same type of responses to what their EMR does for them. So how do we reduce this and how do we get back to that quadruple aim? We go to understanding the need. We have to understand what the provider wants. We have to understand the deliverable. We have to recognize industry mobile trends. We have to make sure it's secure and it's private. We have to optimize the workflow, and we have to make it easy to use. Various researchers estimate that provider burnout is between 33 and 48%, dependent upon the specialty, with an average about 42% overall for the entire medical field. Now, these are the core principles that I govern our IS department with. And we're starting to see that the industry is catching up to some of our thoughts as it relates to the providers and their wants and their needs. And this is how you start to make traction towards this quadruple aim. Now, it's easier said than done, but if you understand these 6 principles as a governing tool, you're well on your way to achieving this quadruple aim. So now we go to the patient's perspective. The patients want fast service. They want quality. They want transparency. They want ease of access. They want fast answers. They want respect and safety. How do we make this equitable? And FQHCs, how do we answer all of this for the patient's experience when 3 out of 4 people would not choose a doctor if they cannot get an appointment within a week? If I were to poll this group here and ask them, what does your appointment booking schedules look like? Are we meeting that goal? Are we meeting the goal that our patients need to see us sooner than 2 weeks, sooner than 3 weeks, sooner than a month? What are we doing about that? How are we making that patient experience easy for us? There's no understanding that urgent cares have 11% market increase in urban environments since they launched themselves. That's not by chance. That's not by accident. It's because of this stat that 3 out of 4 people will choose a doctor if they want to get in within a week. So when we talk strategically in business, from a business perspective about FQHCs, how are we handling this competition? Our competition isn't each other, it's outside. It's these millennials, and I'll tell you my age, I'm 37, I'll be 38 the 24th of this month. So a lot of my friends call me a millennial, but I don't subscribe to that. But how do we handle these millennials who just want to go on their phone and book an appointment? Or how do we handle just telling them that their meds are due or that they need to come in? That's a delicate balance, and that's part of the job of the CIO, to provide those 6 opportunities from governing that we saw on the slide before. So who's right? Our industry is in a dramatic shift. We have the providers, we have this technology in the middle, and then we have the patients on the other end. I think we need to bridge the gap using technology. Now, that's biased because I'm a CIO, but I think that healthcare is starting to catch up to that, thinking that technology is the way to bridge this gap. And we have all heard this at the very highest level. Anyone that's a CIO, we subscribe regularly to the ONC and the CMS and the rules for interoperability that they put out in February of 2019 was a very, very strong indication that they're wanting us to catch up quickly. And we have to make sure that we have the systems in place internal to us that can keep us competitive in this market that's growing. The customer, that's the patient. They want to use maybe a patient portal or some other feature. Next slide, please. And with that is our phased approach. One is to deal with the provider well-being. Phase 2 is the patient engagement. And phase 3 is population health and quality. When I look at this phase, they're purposefully, and this is my strategy as a CIO, my strategy for how I approach things here is we have to look at the providers because they're the ones providing the care right now. We have to engage the patient and what they want. And then we have to understand this demographic so that we have and are able to provide the proper services that can keep them a part of this whole care of the actual patient. Next slide, please. So we have this customer, we have them with healthcare anytime. They want to be able to quickly, again, that 3 out of 4 want to be able to get in. We have them using the patient portal, but they're going to see the FQHC, they're going to see the hospital, they're going to the pharmacy, they're going to a lot of the other different areas that we might not necessarily have this experience. So at the patient's perspective, how do we marry that? Next slide, please. We marry that with mobile technology. And what we say is that by using mobile technology, by educating our providers that this is how we continue to stay competitive, we see that this is starting to bridge that gap between the provider and the actual patient, because all of these millennials, I'll keep talking about the millennials, all of these millennials, they are on their phones, they're on their tablets, they're not glued to the traditional ways of phone calls and things that we use, well, I'll say that used to be in the days of old. But on this mobile experience, there's a lot of things that you can do. You can do a view and printing of x-rays, you can request refills, you can pay online, you can request referrals, you can make appointments, you can access test results, and then you can communicate it internally to your provider team. So we've created a team, which we call our healthcare delivery team, that are answering these messages as they come in. And I'll talk about some of the staggering stats that we have when we took a hard look at some of this bridging of the gap with our patient portal. I'll talk about that right now. So the adoption versus use. So in 2018, we see that patient portal adoption is a steady jump from 90% to 92%, but the actual use is a mere 30%. That's a difference there. Adoption versus actual use is an issue. And then again, I said meaningful use is a department that reports to me. This is one of the meaningful use criteria. It doesn't matter what stage you're in. This is part of one of the core objectives, is the actual patient portal use. Adoption was part of stage 1, flying into stage 2, but now it's getting into adoption. And then once you get past stage 3, going towards the MIPS and the promoting interoperability, it gets a little bit higher on the rating scale. So we as FQHCs have to start to take a look at this now and see how can we introduce not only just patient portals, but patient engagement in totality. How do we use that to our advantage? So we'll go to the next slide, please. So a responsive design. Now, you may say this is a CIO talking about responsive design. Why is that? That is because this is what we have to do, and we have to understand everything from a technology perspective, because that's where our patients are, and that's what we need to understand what they want to see. So when I'm talking about responsive design, I'm talking about the usability and whatever means as it relates to the designs of some of these apps, patient portal apps, and the websites that we're asking patients to schedule with. We're asking them to go on our website or go to our patient portal and schedule an appointment. But the interfaces, the usability of it, it doesn't work. We wouldn't use it ourselves, but we're promoting this to our patients. That's not right. So our job is to promote the change and or addressing of this responsive design in a coding perspective. It's our job to challenge that. We challenge our vendor. What are you doing about the patient portal? How are you increasing it? It's no longer just a nominal tool that we can check a box off and get our providers to be accredited for meaningful use. It's no longer that. This is a business line for us. How do you do that? We pose that question to NextGen, and I'm pretty sure quite a few other people has done that as well. And as of last year, they purchased a new product that will integrate and change the way that they're looking for their patient portal. We as FQHCs have to be on the front end of that conversation. We have to be driving them to do that. They don't know what we know. They don't know the patients that we see. So we have to tell them that these are the things we need to stay competitive in this market. And by doing that, that increases this, not only the provider well-being, but the patient engagement. If a provider can easily say, this is how you navigate the patient portal, because I've done it myself, it's more apt that a patient, knowing that they have that relationship with the provider, that they can keep that going. Next slide, please. So what are our goals? With the patient portal, we took a staunch look at that, and I created a subcommittee that reports to the larger informatics committee. And we said our goal was to re-educate our staff. And we wanted to tell them the benefits of a new patient portal. Now, I highlight new in this slide for a particular reason. All of these actual features have been in patient portals forever. But using the word new, it was a little reinvigorating for not only our patients, but for our staff. So when they were talking about it, hey, here's our new patient portal, check it out, go on it. Not only sign up, but actually use it. Send us a message, schedule an appointment with us. And then go to was to develop the technical reliability and stability of it. That's some of part of what I was saying before, is we have to challenge our vendors to make sure they deliver to us the applications that we need. And then we have to develop company buy-in. You know, in any of our trainings, you know, if you don't have an executive buy-in, things could fall by the wayside easily with a steering committee. So by having the executive buy-in from myself and from others as an organizational goal. So one of our organizational goals for the entire organization is to increase the adoption and use of our patient portal. So by having that buy-in, that made it easier for staff to buy in as well and help us increase our numbers. Next slide, please. So here's where we get into this engagement platforms and how do we make sure we have what we need and communicate to the patients. The patient portal versus the patient health record. So the difference between patient portals and personal health record is when the patient enters some of their own data and then turns it into their personal health record. The patient has the option to share this information when they enter into an organization from an interoperability perspective. I really think that this is where healthcare is going. Healthcare is going back to this personal health record that we will now, as organizations, need to have consent from the patients to accept their information because they will have the most accurate information. What's a prime example of that? If anyone has an iPhone out there, if you're an Android user, I'm sorry you had to go that route, but come back over to Apple when you get some chance. But Apple has their Apple Care and their Apple Records, and then they tie that directly into your Apple Watch. So on your watch, you're storing all of your historical information into the app that sits on your phone for Apple Records. That is actual personal health record. That's an EHR. How do we get access to that information? That's with the slide before from the technologies of interoperability. That's the APIs and that's the HL7s. So one of the things, if you go back a slide just a second for me, and I'll tie it all together, thank you. I want to talk about this because they are important. A lot of the interoperability rules that have come out, they introduce these type of technologies that you need to know and understand what's going on. You need to understand what HL7, and you need to understand what an API is. One of the things that we've done last year is we actually hired a coder that has this as a wheelhouse or the ability to increase that stack. Now, you may say, what does a salary like that look like? But we can talk about that offline. But you need to understand these two levels of interoperability from a technology standpoint, because this is the way that things are going to be exchanged. Now, there's one higher level to this HL7, but we won't even discuss that right now because people just need to understand APIs and HL7s. We can go to the next slide, please. Your phones. All of them, all of these Apple records, these health records, they use this API stack, and they can transition themselves directly into your EHR via HL7 or the API stack itself. And that's how you would get that information in. But in the arc of liability, you need to understand what consent is. And the arc of liability means from point A to point E, what's in the middle, who is in control of that, who owns that data. And anytime we sign an agreement to do an HL7 or an integration with a third-party vendor, we ask them who is in control of the arc of liability. And you get varying responses, but at least you have something on record, because once it leaves your organization or once it's in process to come in, it's at a hackable position. And that's where the privacy and security to the 6 goals that governing goals that we talked about for our department before come into play. So I hope by at this point, you guys are starting to see it come together. So we're coming close to 30-minute time, so I'm going to scoot through these a little bit faster. So next time, so this is our EHR from our mobile, this is our mobile platform from our EHR vendor. And we have deployed this to all 74 of our providers. They get to see their schedules, they get to see the demographics, medications, they can prescribe medications, they can actually dictate to the SOAP note through this actual mobile platform. And it's part of that whole bridging the gap between patient and provider experience to our aforementioned Quadruple Aim. Let's go next slide, please. So this is how moving towards interoperability comes into play. You have your EMR, your PM software, your patient portal, then your HIEs. And anyone that doesn't know what HIE is, that is your health information exchange. It's a clinical repository for CCDs, medications, lab that gets sent to a repository, and that each entity inside or outside of this whole healthcare, your walls, can funnel into, and then based upon matching demographics, you can bring this information into your EHR chart. And that's where, again, governing and making sure that patient engagement experience goes on. Next slide, please. This is just the patient. Think about the patient perspective. And they are going to all of these different type of specialties, these providers, and they are in charge of all of that information. So it's at the consent level that they can give you all of this, and then they have to pay a bill. But in addition to this, let's go to the next slide, please. So here's our success story. So in April of 2019, we reset our patient portal committee. Before that committee, we had 526 users actively using our patient portal. I'm going to say that again, 526. If you remember our very first slide, we are at 49,050 patients, unique patients, 150,000 visits. We had 526 using. After the executive buy-in, after April of 2019 and a relaunch of the new patient portal, this number from August of 2019 is 3,984. To date, we have 5,987 patients, and this is a current as of January, patients using our patient portal. Not just adoption, usage. Now, we know that the standard for meaningful use is 10%, and we're trying to get there. But if you just look at where we were just a year ago, less than a year ago, it's dramatic increase. And a lot of this comes to why we're doing this demo for this webinar for CareMessage is because of how this whole patient engagement plays into the success of an IS department. Patient engagement, from my perspective, has a lot of components. Now, I know I talked about a whole bunch of other stuff, HIEs, I talked about technology, I talked about watches, but I didn't talk about text messaging, I didn't talk about how you engage the patients from the recall perspective. And part of what we do is we make sure that we do these things in a way that makes it equitable and treat patients as if they were human. So prior to me starting, we were sending out letters, we were emailing out of the system. Patients were getting inundated with so many messages. If I were the patient, I would be like, I'm not going to that place because they're just not coordinated. They're not understanding. One hand is not understanding what the other hand is doing. And so by using platforms that have quality metrics, that have texting, that can touch your database and actually can send out scheduled messages like a CareMessage or something like that. And I'm not pimping CareMessage, but they are the leader in the pack. And it's a reason that I signed up to do this, is because of what they provide. It's very clear that these are the tools that you need. And these are the tools that not only have a business success case, but they have a patient and provider success case. A platform that can give you all of the tools that you need, that you can automate, and you don't even need to worry about it. And a lot of the APIs and the HL7 interoperabilities that they possess make it great, and it makes it great for the FQHC market. I don't know what's after this slide, but I've just been talking. There we go. Yeah, so here's a great slide for organizational steps for success. I'm sorry that if I missed any of the slides and then talk about them. I love talking about these things. But one is just establishing a vision, creating a culture of engagement, employing the right technology. You know, some of the IT misnomer is that we spend all the money, but if you spend the right money, then you will get the dramatic ROI from a business perspective. So it's employing the right technology and then empowering your patients, and then be ready to move. And when I say be ready to move, be ready to change. But ready to change means that your foundation is good. So if you were, when you get these slides, look at those 6 governing opportunities and use that as your foundation. If that foundation is set, you'll be ready to move at the drop of a dime. I don't know what's after this slide. I think that
is it.
That's it. Oh, I did it. A little over, but I did it.
It was great. Thanks so much, Isaiah. And let me see if there's any questions. I see there's some action in the chat. Let's see. Yeah, it looks like we have one question from Lawrence saying, we have a substantial population of elderly who don't use technology. How would you suggest addressing this?
Oh, that's a perfect question. I love that question. I love that question because we have a great Medicare population as well as elderly population as well. And then as we continue to shift all of the statistics of the United States, point that we will have more elderly population than ever. How do you deal with that? What we do is you can use internal, which would be an internal cost. You can use kiosks or you can use mobile technology again. So we have iPads that have some of our intake forms that we use to assist this elderly patient at the point of care in the actual waiting room. So we use mobile technology, we use kiosks, and we use our care coordination teams to be the liaison between the front desk and that elderly patient.
Perfect. Thanks, Isaiah. And then we have another question, and everyone feel free to pop in any questions. Isaiah, they can ask you absolutely anything, right? No,
Absolutely.
No banned topics. Perfect. Mike has a question. I'm just going to go ahead and read it aloud. We have an environment that looks much like yours, next gen in the infrastructure side of things, and we also embarked on delivering patient engagement, quote unquote, platforms for our patients. We found that a lot of the automation provides most of what we're after, but stops short of complete and tight integration with the EHR. Have you found similar challenges on things like patient self-scheduling, for example?
Yes, absolutely. I'm actually sitting back in my seat because that's the exact point where I'm at now. So my challenge to you, I don't know, Mike, if you're a CIO or what your role is. We can definitely talk after this. What I have decided is that we're going to build it from scratch. And what I mean by that is we're going to put all vendors at the table and we're going to design this thing. And what I mean by that is what's best in NextGen, what's best in MedFusion, what's best in patient scheduling. We're putting them all together to have and design something that works best for us. What's best on our website, we're going to combine that entire kind of platform and create it ourselves. And we've started our initial conversations with that. And I would love to talk to you more about that. Maybe that's something we can collaborate with, because if you have some of the same environment we can, this can definitely be passed off. So I got tired of that not saying it was available. And I said, let's talk about this and do it together. If I were to speak tactically about that, not strategically, just from a technology perspective, all of the interoperability runs through Mirth. And that's all your HL7s, all of that thing specifically in NextGen. And NextGen owns Mirth as the platform. Use that to your advantage. That platform gives you the ability to customize in and out exactly bidirectionally what you need to do. Happy to talk to you afterwards, Mike.
Thanks, Isaiah. And yeah, Mike confirmed he is a CIO, and I can definitely connect you both via email after the webinar. Great. In case you want to talk further. We have a couple minutes and 2 questions pending. One from Mark that says, have you been able to increase your enrolled population coming in for annual wellness visits by using these technical tools?
Absolutely. Our wellness visits are up. I don't have the percentage or numbers. It's up to the point where it's conflicting with our patient portal appointments, which is a good problem to have, because our patient portal, it's overriding where our Medicare wellness slots are scheduled. So we're running into that right now. Our decision is to prioritize Medicare wellness visits, and we're reconfiguring, using that Mirth channel, reconfiguring the patient portal appointments to route them differently. So absolutely, our Medicare wellness visits are definitely up because of the technology we have in place here.
Perfect. And we have one more question as of now. If anyone else has any questions, feel free to pop them in, and we can answer them via email afterwards for sure. But our last question right now is from Ebony, and she asked how you leverage technology to address no-shows in your FQHC population.
The dreadful no-shows, I'll tell you what our future plans are, and I'll tell you what our current plans are. So our current plans are, because no-shows directly affect the bottom line, and we have developed internal dashboards to maintain that on a outreach perspective, using our care coordinators to get them back in if they no-show. And then very quickly, we will be moving to CareMessage to help us with that no-show rate, to decrease it. So that is our future and what we do currently.
Thanks, Anthony.
Perfect. Well, thanks so much. I might connect you with one other person who I think has a more detailed and technical question. So I might just connect you via email. Isaiah and Jacob, you provide your email. So I'll bridge those connections afterwards. But Isaiah, any last few words to the audience before we sign off?
I thank you guys for speaking with me. I really do consider myself a part of this community. I'm open for all questions. I'm open to hopefully asking you guys questions as we continue to embark upon this. Just holistically, collectively, I think we need to continue to do more of these things from the technology perspective as healthcare continues to evolve. I'm very concerned with our competition that's right in our background, the CVSs, the Walgreens. I'm very concerned with that. And I want us as FQHCs to band together to do what we need to do internally to beef up our infrastructure with our IS department so that we understand what's going on internally, but also externally with our data. So it's really been my charge to speak that message, is that FQHCs have to continue and support their business. This is not just supporting internally, support the business with a functional IS department. Again, I was being snarky, but I'm very serious. Just having a network admin and a help desk person is not it. You need to have more. And you know, there's less and less CIOs than there are COOs, and we need to reduce that.
Well, thank you so much, Isaiah. That's been a great presentation. I know a couple other questions have rolled in, but we'll just, I'll make sure to follow up with those via email and coordinate with you, Isaiah, if there's anything we can't cover. But thank you so much for your time, and thank you everyone for joining us today. And feel free to reach out to me directly. My email's right there, jot it down, reach out to me if anything comes up. We're happy to support this community in any way we can. And thanks again, Isaiah. And I hope you guys have a great day.
Bye-bye, everybody.
All right. Take care, everyone. Bye-bye.
Thanks, Isaiah.